Anthony, I wanted to ask you, now that we have the ability to detect these low levels of disease, and we've got an agent that's approved to treat these low levels of disease, where does transplant fit into all of this? We haven't talked about that very much. When do you think about transplant in ALL patients?
Well, if somebody, okay, so if somebody is, so my philosophy is if you're using an AYA regimen, the patient does not have any high-risk cytogenetics such as hypodiploidy, Philly-like, 411 are the main bad players. And if they become MRD negative, then I would not transplant that patient. I would just follow them. I would continue them on an AYA regimen and follow them over time. If somebody is MRD positive, all they have, so if somebody has a poor cytogenetic abnormality or mutational abnormality, then I would give them induction therapy, get them into a remission, and if they have an adequate donor, then I would take them to a transplant. For somebody who's MRD positive at day 28 or after consolidation treatment, that patient, again, I would give blinatumomab to make them MRD negative. And if they have a good donor, then I would also take them to a transplant based on the German study for MRD for the BLAST trial. And in that study, where I think the result, if you look down, if you look at the data for patients going to transplant, there was a higher transplant mortality rate, because if you look at the type of transplants that were done on these patients, a lot of them were 8 out of 10, 9 out of 10. A lot of centers were using cord blood, so you had a much higher transplant-related mortality. So if you don't have an ideal donor, then I would not take. Then I would just rely on the blend and follow the patient and not transplant the patient.
You just, sorry, I was going to say, you just brought up a brilliant point, because when I talk to my transplanters, their response is everyone has a donor.
Well, everybody has a donor, but I mean, if you start moving to, so I mean, a haplotransplant nowadays, giving post-transplant Cy is a safe is almost like doing a fully matched, unrelated transplant. But when you're moving down to the 8 or 9 out of 10 mismatched transplants, then the risk is much higher. If you have to go to a cord transplant, we have where the cell dose is a little bit low, and you have a big adult patient, then the risk of that transplant is much higher. And I don't, yeah.
What do you do with the patient that's still positive after blinatumomab, still MRD positive?
CAR T cells.
I mean, so I think that's, I mean, those are refractory to blinatumomab if you're not able to kind of get into, I think.
Or if they CD22 and I don't have my CAR T cells, then I might give that patient inotuzumab, or there's now there may be new novel agents coming along like venetoclax that also may have a potential benefit. But that type of patient, I would consider giving CAR T cells to.
I think those are the difficult questions, because sometimes if we see MRD positive patients, we want them, even if we decide to go to transplant, you want to turn into MRD negative before going to transplant. But what if we're not successful and they're still MRD positive after that attempt? I think then if we have an alternative option, should we pursue that option to try another attempt of MRD negative, or we just say, you know what, this is the best that we can do, and then go to transplant with an MRD positive disease and accept the risk that we will take. I think these are the difficult questions.
If you transplant somebody with MRD positive disease, the outcome is not zero. There is
correct, exactly.
There is some survival,
Right, it's not as good as MRD negative,
correct.
But if that's best we can do, then should we, I don't think it's be off the table, but if an alternative, better options, then, or as the good option, then I think most of us will pursue that option before going to transplant if we still have a shot at getting MRD negativity. But
MRD negative how?
You mean by which assays, or?
Yeah, I mean, so in terms of the transplant decision making, there was data by Pulsifer and colleagues showing that the next generation sequencing approach was able to, again, because of their lower methods of detection, were able to pick out, again, in the pediatric space, patients with very, very low disease burdens who still had a heightened risk of relapse over time. And so do we use our conventional flow approach? And again, this is a very different question I'm asking. It's not about is there MRD or is there not, but which method do we use for making a transplant go, no-go decision?
I mean, we definitely don't have a prospective data to kind of guide us to that. I think, of course, deeper the better. But if there's somebody's 10 to the minus 4, is that kind of good enough to go to transplant? I think it all depends on, is this the best that we think I can do? If somebody, I started with the blinatumomab first cycle, started with the 10 to the minus 1, and I got to the 10 to the minus 3, I may just give another cycle to see if I can get it a little bit deeper to go to transplant. But somebody had kind of the 0 changes from the very beginning to an end, I'm not so sure for the cycle is going to change anything. So I think a lot of factors going to go into it. If there's an options to go a little bit deeper, even theoretically thinking that will be better, I think a lot of retrospectives support that. But there will be ideal situations. But there's also good data for the transplant. The MRD negative is better, but just because MRD positive, and to a certain degree, we're talking about a little degree, 10 to the minus 2 or 3 or lower. They still have benefit for the transplant for those patients, assuming that's again the kind of the best we can do, kind of at that time. And we still don't have a MRD-directed CAR T-cell therapy yet, so I think that's kind of another thing that we were not able to kind of treat.
But I think most of the transplant data have used 10 to the minus 4 as a cutoff. So until you know what the influence of like a 10 to the minus 6 is, I mean, I would still use my 10 to the minus 4 as my cutoff about prognosticating about a transplant.
That's fantastic. It's amazing how far we've come. I remember when we were using morphologic CRs, and I'm not that old, but when we were using morphologic CRs to make that determination of transplant.
Yeah, I don't think more. I think more.
None of us are doing that anymore, exactly. But that wasn't that long ago.
So Bijal, you've got this patient. Let's say they failed blinatumomab. For one reason or another, CAR T is not an option. You've settled on giving them inotuzumab. Your transplanters are telling you, we're ready to go, we've got a donor, as soon as you can get this patient into remission or MRD negative. How do you manage inotuzumab in the setting of a transplant-eligible patient?
Very challenging. And what my transplanters are telling me now is they want 4 to 6 weeks between the last dose of inotuzumab and the transplant for fear of veno-occlusive disease emerging. And that is not always sufficient time span in which to keep patients MRD negative, meaning after you stop your inotuzumab, we still think that there's residual disease which is going to percolate up. And that is extraordinarily tough. Sometimes we'll try.
I remember the INNOVATE trial, high rate of MRD negativity, but you look at that survival curve and
it falls fast.
It falls fast.
And the thing to remember is that was a flow cytometry-based MRD assessment. And the other thing to remember is as we move into salvage 1 and salvage 2 and salvage 2 and beyond scenarios, the impact of MRD negativity becomes less, meaning in spite of MRD negativity, we can see relapses occur more frequently than in the frontline setting when we achieve an MRD negative endpoint. And so keeping in mind that there's probably 6 logs below 1E6, so we're probably, if we really wanted to eradicate disease, talking about getting down to 1E12. I don't know that we're ever going to get there, but that's really what we're talking about in terms of eradicating leukemia. So even achieving a 1E6 threshold, there's still disease left behind, and in these patients who may have very proliferative disease going into their inotuzumab, boy, you have to act fast. And so what am I doing? Trying to bridge them however I can. Sometimes that's Marquibo, sometimes that's steroids, sometimes that's pump without the 6MP, but it's, strategies to try and maintain that remission during that period off the inotuzumab as we're trying to get them to the allogeneic stem cell transplant, but there's no easy way to do it. One of the things that I'm looking at, not just pre-transplant, but now also for the post-transplant relapse, which is another extraordinarily challenging population to take care of, are some of the regimens that were presented at this 2018 American Society of Hematology annual meeting, the mini CVDs plus inotuzumab, things that may allow me to fractionate the inotuzumab, essentially expose them to lower doses in the hopes that perhaps we may have less of a hepatotoxicity signature with a preserved remission rate.